And with this, I have an audio that I hope.
Greetings. My name is Muller Pierre-Louise, and I am a third-year medical student.
Okay, could you guys hear that? I'm sorry.
Yeah, we can hear it.
Okay, so I just want to make sure first, and then I'm going to introduce them though. Okay, so this presentation is barriers faced by Muslim children receiving treatment for autism spectrum disorder. This was presented by Dr. Abbas Naqvi, who is currently a postgraduate year 2 psychiatry resident at Jamaica Hospital, along with Dr. Asjad Bashir, who is also a postgraduate year 2 student, psychiatry resident at Jamaica Hospital. And then the audio that I'm going to be playing is from contributing author Muller Pierre-Louise, who is a third-year medical student at the Ross University and is rotating with the psychiatry department at Jamaica Hospital. So let me...
I will be presenting a case report titled Barriers Faced by Muslim Children in Receiving Treatment for Autism Spectrum Disorder. The authors of this case report are Dr. Abbas Naqvi, Dr. Alina, Dr. Asjad Bashir, and me, Muller Pierre-Louise. Autism spectrum disorder is a pervasive neurodevelopment disorder characterized by deficits in communication, social interactions, and stereotyped or repetitive behaviors. Timely access to early interventions can significantly improve the lives of children with autism. Religious and cultural beliefs have emerged as barriers to diagnosis and treatment and often determine whether or not families can discuss their child's relevant symptoms with physicians, let alone seek out early intervention. Existing literature shows there is a significant lack of awareness of autism spectrum disorder in many Islamic countries, and even among those who have appropriate knowledge and are willing to seek treatment, there is a shortage of resources and services available for affected children. Now draw your attention to the chart titled Opinions About Autism. Y-axis represents the frequency, X-axis represents the opinion, and blue is agree, red is disagree, and yellow is I don't know. The chart illustrates the responses of parents regarding different opinions on autism, as per a survey given to Pakistani parents to evaluate autism-related knowledge, signs, symptoms, and treatment. As you can see, parents mostly agreed upon autism being a mental disorder. The child becomes unsociable, and an autistic child has special talents and attributes. A significant population of parents disagreed on considering an autistic child mentally retarded. Upon different opinions on autism, the parents were unsure and responded with, I don't know, especially in cases of considering autism an inherited disorder, if autism is preventable, and if autism is caused due to parental negligence. Now, if you bring your attention to the two tables on the bottom left, in a survey of preschool teachers in Yemen, a Mann-Whitney test was utilized to demonstrate the ability to detect behavioral issues in videos of two different patients. Video 1 showed a child diagnosed with autism spectrum disorder, and video 2 showed a child diagnosed with ADHD. The table on the left shows ranking of patient descriptors, while the table on the right shows whether or not teachers would decide to refer the children to specialists. All of the preschool teachers were asked if they thought there was a problem with the children in the videos. However, not all of the preschool teachers confirmed that the children had problems. 75% of the preschool teachers answered that the child in video 1 who had autism spectrum disorder did not need to be referred to a specialist. Meanwhile, 25% of those preschool teachers believed that the child needed to be referred. In contrast, the preschool teachers' opinions on the child in video 2 who had ADHD were significantly different than their opinions on the child in video 1. In total, 60% of the preschool teachers confirmed that the child in video 2 had to be referred to a specialist and that his parents should be told to do so. On the other hand, 40% of the preschool teachers confirmed that the child with ADHD in video 2 did not need a referral. So let's talk about the case. A 10-year-old Pakistani male presented with his mother having auditory and visual hallucinations and increasingly aggressive behavior with intermittent outbursts. Between June 2018 and May 2020, the patient underwent extensive pediatric behavioral and neurodevelopment testing and diagnosed formally with autism spectrum disorder, high functioning. The parents were separated in 2019 after a long history of domestic disputes that were verbal and physical. The father's family reported with extensive mental health illness, and the patient's brother also had autism spectrum disorder. In January, after being given the autism spectrum disorder diagnosis, the patient and his family were forced into a shelter system. In the hospital, in the ER, auditory and visual hallucinations, engaging others in the room in full conversation, often profanity-laced or in an aggressive tone. Admitted to the pediatric unit with recommendation for transfer to inpatient child and adolescent unit. The patient had continued intermittent outbursts, and the pediatric team initially medicated the patient with low-dose Haldol 0.5 to 1 milligrams PRN. Psychiatric consultation advised to discontinue this, preferring Risperdal 0.5 milligrams BID, which led to stabilization of behavioral and emotional disturbance. Discharged to the facility with inpatient child and adolescent services, and on follow-up, patient is demonstrating improved behavior with improved school functioning and fewer outbursts. Autism spectrum disorder is complex, has multifactorial etiology with a strong underlying genetic component. The diagnosis is comprehensive evaluation involving months to years of testing. Treatment is early, and behavioral and educational management is key to improve outcomes. Medication, SSRIs, are for the repetitive and stereotype behavior and anxiety, and antipsychotics for the aggression and self-injurious behavior. In some cultural interpretations, the disorder is perceived to be acceptance of Allah's will, where parents deem spending money on intervention as a waste. In Pakistan, for example, the idea, disability, is sometimes taken as a sign of punishment, and hence the families tend to hide the individuals with disabilities, fearing the negative stigma that is associated with the disorder. So in conclusion, there is insufficient data concerning the prevalence of autism spectrum disorder, owing to factors such as cultural and religious perception and the inability to diagnose effectively, likely requiring a combined effort on the parts of parents and healthcare professionals to raise awareness. Improvement in teacher education is necessary because of a large gap exists between the knowledge and understanding of primary teachers regarding special education in general. Thank you guys for listening, and also thank you, Michigan State University Department of Psychiatry, for giving us the opportunity to present this case report.
Okay. So our next presentation is on Muslim mental health in Brazil, violence, Islamophobia, and social suffering, from Camila Motta Paiva, a PhD candidate in psychology at University of Sao Paulo, Brazil, and she develops a thesis entitled Body, Mind, and Heart, an ethnography of mental health in Brazilian Islamic communities. During her master's degree, she worked on the theme of sexuality in Islam with Brazilian Muslim women. She is also an associate researcher of a group of anthropology and Islamic and Arab contexts. So let me... Let me open up her, because she has a video, so I'll get that up. I'm gonna play it while I open.
Good morning, everyone. My name is Camila. I'm a PhD student at University of São Paulo, Brazil. I'm thankful for the opportunity of presenting my work for the second year. This time, I will emphasize how topics related to violence, Islamophobia, and social suffering are showing up in my research about Muslim mental health in Brazil. Well, the presence of Muslims in Brazil is best known due to the Arab migration flows, especially from Lebanese, Syrians, and Palestinians who came to the country in different waves at the end of the 19th century and throughout the 20th century. However, the history of Islam in the country has an earlier origin. The first communities were built in the first half of the 19th century by the Malis, enslaved African Muslims, but this fact is little known by Brazilians in general, Muslims are not. This is important because for a long time persisted the myth that Brazil would be a harmonic and conflict-free country. According to Schwartz, one of our leading anthropologists and historians, we Brazilians prefer to see ourselves as happy, peaceful, tolerant, and friendly people. We usually affirm that since the beginning of our history, we have been mixed, miscegenated, and therefore we would accept and deal very well with differences, whether racial or religious, but we neglect the fact that our country was formed by the language of colonization and slavery, which is a bitter side of our history. Slavery was allowed for more than 300 years in our territory, which was the last one to abolish this form of forced labor in the Americas. So it's obvious that the social issues we face today in the country, violence, poverty, hunger, homelessness, insecurity, have a face crossed by class, gender, and race, and which maintains a profound structural inequality. All of this also appears in the work I'm conducting about Muslim mental health. So considering the main theme of this year's conference, I will briefly mention two cases of two young Brazilian Muslim women who highlights how the socio-political dimension is directly related to their mental health. The first of them establishes a connection between anxiety, violence, and social suffering. This woman, born and raised in a small city, decides to move to Rio de Janeiro, one of our most famous and beautiful cities, known for Christ the Redeemer, sunny beaches, the carnival, but unfortunately also for the violence, as it is one of the most violent cities in the country. So when she moved to Rio, a big, violent, and unequal city, all her anxious symptoms intensified there. She tells us that on several occasions she heard gunfires near her house and that this triggered very intense crises. According to her, the symptoms persisted for a long time and then got worse after a very specific event, the murder of the city councilor Marielle Franco, which took place on March 14, 2018, when she and her driver were chased and executed in the central region of Rio de Janeiro. The execution of a Black woman, feminist, activist, defender of human rights of the poor, the vulnerable, was understood as an attack on all these agendas. So she, the Muslim woman I'm talking about, who is also a Black woman who identifies herself with feminist and social causes, mentions that after this episode, then she really started to panic. In her opinion, sometimes something social happens and it can serve as a trigger for a lot of conditions. And we allude to Vinata's ideas about how violence descends to the ordinary, to the everyday life, and affects bodies and subjectivities. The other case I want to present to you is about an Islamophobic attack the second Muslim woman experienced in the city of São Paulo, the largest in the country. She was walking alone near her house, and then she was hit by a stone. She heard someone saying something like, "You damn Muslim," threw the stone at her and ran the other way. She didn't have her suffering recognized by her religious community, as they affirmed there was no Islamophobia in Brazil, that the violence she suffered happened by chance, just an isolated episode. This was very painful for her. She tells us that she embraced Islam precisely because of its message of social justice and community support. But when she needed the most, the community turned its back on her. Well, unfortunately, these two cases of these two young Brazilian Muslims are part of a set statistics we have. According to World Health Organization, depression and anxiety disorders have alarming rates in Brazilian society. Brazil has the highest rate of depression in Latin America, and anxiety disorders affect 9.3% of the population, which ranks Brazil as the most anxious country in the world. As we know, Muslims are not immune to these issues, and to understand Muslim mental health in Brazil, we must reflect on this broader social context. Finally, it's important to keep in mind that in Brazil, there is currently a social and political scenario full of tensions, full of turbulences, that unfortunately have been increasing intolerance against minorities. So I'm certain that any research about the relationship between mental health and religion must pay attention to the social-political dimension. And that's it. Please let me know if you have questions, concerns, contributions. Thank you very much for your attention. See you.
Okay. Our next presentation is on Muslim Women's Collective, Psychoeducation and Support Group organized by and for Muslim women to promote collective healing, by Qurat-ul-ain Gulamhussein, who is a PhD candidate in the Counseling Psychology program at the University of Minnesota, Twin Cities. Her research and community involvement revolves around identity development, socialization, and resilience in the Muslim communities in the United States. So she's here today, and I can open up the, hold on, sorry.
It's okay.
There we go.
Awesome. Thank you, Mary. Well, first of all, assalamu alaikum, everyone. Good morning. Thank you for showing up to this super early morning 8 a.m. poster session. I am hoping to make this interactive, just trying to replicate a normal poster session here. So if you can, I would strongly encourage you to turn on your cameras. I do like to see the other people on the other side. If you are capable, I would appreciate that a lot. Thank you. So my name is Qurat-ul-ain. I'll be presenting on behalf of my team here on Muslim Women's Collective. And as Mary introduced, I am a PhD candidate in counseling psychology. So I was really excited to be able to contribute and kind of play the lead facilitator role for this project. So I'll start off on the left and guide us through until the end, and leaving maybe time for discussion and questions towards the end. And this is a project that, you know, we've been doing for the past 1-2 years, and we're definitely wanting to continue. So wanting to get to know your thoughts. How do you see this playing out in your communities? If there's feedback that would be helpful for us to keep in mind moving forward, that would just be very, very productive for us as well. So let's start on the left over here with community needs, right? We know that from previous research that there are lots of stressors affecting Muslim communities in the United States today. So things from, you know, just general life stressors that everyone kind of experiences, right? Work-related stress, family stress, this physical, mental health things. But that's kind of exacerbated when you add, you know, religious discrimination, racial discrimination, and that racialized just nature of discrimination that people feel that is very much systemic for Muslims. We know that is Islamophobia. So we have the stats. We know that it does affect people's, you know, health and well-being. And when we think about the flip side, right? What are the services out there? Often we see that it's not very culturally sensitive, though there is definitely a push specifically in our time right now to make those services culturally sensitive. But when we think about, you know, how limited availability there is in our world today, thinking about how those mosque-based group services could be one way of meeting that gap, right? So when we think about places of worship across different religions, think about places of worship specifically for When we think about immigrant communities, right? Even if it's like churches where, let's say it's a Korean majority, Korean American majority attending community, there is research that shows that those places of worship don't just serve as places of worship. They're social centers, they're centers of support where people can kind of get advice or support around different domains in their life, not just limited to religion. So thinking about how can we use that concept for Muslim communities? A lot of the past research that has been done on coping through religious organizations, places of worship has been very Christian-based, which is great for us to learn from, but also there is quite a need to understand that from a perspective of mosques and Muslim communities. So I've cited a couple of studies here that talk about, the qualitative studies that have interviewed, Muslim people and trying to understand how can we integrate those two domains or worlds, which kind of feel very different for a lot of people, right? How can we bring them together to think about this whole health approach? And findings have shown that, it can be helpful if there's a way to integrate religious and cultural kind of stories, whether it's hadith, whether it's different traditions. There's different ways of making those services, those mental health services, feel more accessible. Now think about when, Muslim communities go to the mosque, if we bring those services right at the mosque, it kind of reduces the stigma, right? Because there is that systematic incorporation that's happening. It also increases accessibility, that they don't necessarily have to go elsewhere. And then there's just a different kind of unique power when those services are being led by community members themselves, because there's that trust already. Like I can imagine all of you, if there's a group that you already identify with, it makes it way much easier to kind of seek services with them, and more so in a way that feels organic, not so much an expert kind of telling you what you need to know about yourself, but feeling that community. And when we think about Islamophobia, we think about religious discrimination, more of an interpersonal level. We also think about how accessing support and services through the mosque can also strengthen people's Muslim identity, something that they're probably trying to pursue, right, as they're navigating living here in the US, right, with all the things that folks face. So when we think about this whole broader context, right, that of course identity is complicated, how Muslims will respond to their identity, to mosque-based services will of course vary. Muslim communities are not a monolith, of course, but keeping a broader context in mind that there might be benefit in having mosque-based group services leads us into this current project that I'll be talking about. So in 2018, there is this mosque that I participate in as well, since I moved here for grad school to the University of Minnesota, Twin Cities. So we have this mosque. It's in, more of suburban Minnesota. It serves a Shia, largely South Asian community, which I'll talk about in terms of what does it mean to have, a mosque that's serving like a diverse community, racial, ethnic wise, and then how people, what are the barriers or strengths to that when introducing these kind of group services. So knowing that community context, it was the first time in 2018 where the mosque board introduced this panel discussion, which was so powerful. I had a wonderful turnout where they asked, a sheikh to come in to speak about, mental health kind of struggles and strengths and coping from an Islamic perspective. And they also brought in a Muslim psychologist who talked about how we can use, more professional evidence-based practice to integrate both of those things to make it more accessible and make more sense to people in the community. And, you know, people were engaged. They felt like this made sense to them. And also after the event ended, there was a lot of discussion and demand coming from the women's side as well, talking about, you know, this need for wanting more of these supportive spaces in a more regular, consistent fashion. So thinking about a place where they can not only learn about coping, but also be able to lend support to each other and talk about, you know, both their struggles and their strengths, like what is going well for them and how can we just be there for each other. So that's where we come in. You'll see our names on the top. There's 5 of us. And we wanted to help create that space that, you know, we heard feedback on that. And I was super excited because I felt like I could contribute some of the psychology skills that I was learning and knowledge in grad school back to the community and help them guide me in how, you know, we can use those skills collaboratively. So we started in 2019, Muslim Women's Collective, with the goal of providing this safe and intimate group space. So we're in the middle column right now in terms of psychoeducation, supporting Muslim women. When we wanted to launch this, we wanted to make sure that we're really honoring the voices of Muslim women in the community who will ultimately be participating in this project, right? So we surveyed them. We surveyed 44 women, asking them about their specific needs, things from what times are you most available at, you know, where are good locations for you? We also asked about specific topics that they were interested in. So we offered a potential list, and then we asked for their feedback as well. So that was helpful. And then remember, we're still working within an organization, right? We're working within the mosque context. So then we got some feedback from the mosque board based on, you know, previous kind of events that had happened, what was successful, what were maybe some roadblocks for us to keep in mind. And ultimately, you know, from getting to hear from everyone, it made sense that, you know, the mosque would be a central location where we would be holding these events. So then coordinating with the board and getting space and time to use that space. In 2020, once we started off all of this planning, we launched our first meeting. We were super excited because we were able to do it in person. It was a great turnout. And this was right before the pandemic hit. So that was interesting. We felt super lucky that we were able to get that, you know, get that one group meeting in. And then from there, we switched to Zoom sessions. And to date, we've held successfully 6 meetings in total. And there's a range of participation and how many people come. It's ranged from 5 people to 20 people. So then it also depends on the format of the group. When there's a smaller group, we kind of just stay all together. When it's a larger group, we've tended to go into breakouts and then come back together as a larger group to maintain that, that core concept of, you know, providing that more safe, intimate space, right, where people can have those discussions. And women have, you know, the identities they report, they're coming from different ethnicities. So again, largely caveat being, you know, South Asian here, but a couple of other ethnicities as well, which was interesting. And I absolutely loved the diversity in age as well, where women range from age 18 all the way to 70. So lots of different perspectives, a lot of both learning from each other and also noticing when there was disconnect, right, happening generationally and how we could navigate that. So we're on the last column now on impact and reflections. So we jotted down some, you know, some themes that came up as part of our discussions and, you know, purposely leaving out personally identifying information, trying to keep it confidential, but still these were some of the emerging themes that kind of kept coming up across our different sessions. So first we have, you know, just exploring how folks navigated discrimination and life stressors. So things from, you know, college students and grad student, like going over to another college away from home, away from their community, in a place that was, you know, where she really felt like a minority, and she wore the headscarf, and how she kind of navigated that, where people would give her looks or different comments, just sharing her struggle in a space where she felt like other people could also understand, was supportive. And that's just one example of more of that interpersonal discrimination. But also we talked about, you know, kind of the discrimination that maybe we also endorse in, right? We also enact. So when the George Floyd movement happened here over the summer, because we're right here in the Twin Cities, right? That was a big thing that came up for us. You know, what does it mean for us as a racial religious minority, you know, thinking about how can we work on that interracial solidarity? How do we talk about it within our families? So that was coming up for sure. And then people talked about just general life stressors. Again, there's a range of age, so people talking about physical health struggles that kind of feel inevitable with age. How have they been navigating that? And when we think about, you know, life stressors, we think about discrimination, gender is a large part. So the group being focused on women and understanding what are the gender roles that were expected from their community. For example, if they lived in more extended kind of family context, what were the struggles that were coming up? And in that, I remember there was a particular time where it was really powerful that there's, you know, a grandma, a daughter-in-law, and then the daughter as well, all three generations being present and talking about, you know, what is one person's experience in the same household? And how do you kind of negotiate those expectations where one woman maybe has lived at home, you know, most of her life, and the other one is going to work, and the other one is also going to college, right? So the experiences were very different. And at the beginning, you know, it felt like there hadn't been much conversation outside this space to talk about these things. And this was maybe one of the first spaces where people were bringing up concerns. And then being open. I think openness was a key thing that came up for a lot of participants, where they were open to hearing and learning about different perspectives and learning, you know, cross-generationally, what can we build on from each other. And then I mentioned that, you know, it is a Shia majority serving mosque. So understanding, you know, at the beginning, we would start off with mindfulness, but what mindfulness looked like was reciting a prayer. And then reciting it in Arabic, reading the English translation, and then discussing it, and how that tied into the discussion topic for that week. How did people kind of make sense of that based on their own struggles that they went through? And when we think about, you know, the main goal of this whole process being that collective healing, of course, it's not just individual based, it's community based, it's systemic based. So then there were needs that, you know, were needed to be conveyed to the larger mosque level about how do we address this as a community as a whole, not just women, but everyone included. Now, I went through the theme super quick, and I'm kind of keeping my eye on the time. I'll end with just the lessons learned, then open it up to discussion and comments. You know, my role as the lead facilitator is something that I noticed that it was different, of course, from a therapy group, right? This is not a therapy group. And most of the groups that I had led so far co-facilitated were therapy, since I'm a counseling psychology student. So this was a different experience for me in that I was also able to share. I was able to seek support as well and talk about my struggles and talk about what has worked for me. And at the same time, there was this cool insider-outsider shift that happened where sometimes I'd be considered the expert, you know, okay, she's going for a PhD degree. and, you know, people asking me, can we see you outside of sessions, outside of these meetings, right, for therapy? And while I had to navigate those, but also that opened up a door for me to then reduce that stigma of accessing, you know, more traditional therapy services and kind of make referrals and talk about what that process would look like. What does it look like to make an appointment? What does it look like to go to your first therapy session? So that was interesting. And then some barriers that came about, you know, all our meetings were in English. So what about women in the community who don't feel as comfortable with English? Or if it's a largely South Asian community, what about folks who are maybe Arab, who are still attending the community? How comfortable do they feel coming to this space? Also, when we transitioned to Zoom, it was, you know, requiring internet resources, computer literacy, privacy at home to be able to participate if they, you know, don't have childcare or other things going on. And then finally thinking about, you know, it is a small community, and especially when there's different family members involved in the same group, what kind of privacy exists? How comfortable are people? Are they, you know, wondering whether they'll be judged or things like that? So those things kind of came up, and I think there were important lessons to be learned, and keeping, you know, in mind those things as we move forward. But I'm going to pause there. I could probably talk about this all day, so I'll pause and see if people have thoughts, questions, feedback.
Hey, assalamu alaikum, this is Hamada. I'm going to start out. You know, I have actually a lot of thoughts and questions, and I don't want to dominate the conversation, so I'm happy to continue with you offline. One is from the program perspective, and the other kind of part is the research methodology. From the program perspective, so my understanding is that this is more of a program that you want to replicate and maybe scale up and spread to other programs. So did you develop a manual or kind of a guidance, standard SOP, standard operating procedure to guide others? Of course, it's difficult to replicate what happens organically in support groups or in group sessions in general. But that's my first question, is how are you kind of providing how are you manualizing this, if you will? That's one question. The other question from a research methods perspective is, you used the word survey in that second column, but it wasn't clear, was it a survey, was it actually mixed methods where it's more qualitative, you're collecting, because then in the results are more like themes. So was it more of a qualitative study, or it seems like especially with a group setting, this would work well methodologically as a qualitative study. And the last question is, or suggestion is, you know, we're living in COVID and we're trying to get out of COVID. This is a great opportunity to compare, you know, the experience, you know, online versus, you know, face-to-face, and what's the pros and cons. I mean, we kind of think we know what the pros and cons are, but have the actual participants report what their experiences are online versus face-to-face. And I'll stop there.
Yeah, 3 great questions. Look at that. Yeah, I'd love to talk more offline as well. I think that would be super helpful. So in terms of protocol, well, first off, this project was the first time it ever happened. So we were just planning to kind of focus on this specific community and keep moving forward. So I think it would be really cool if there are other communities who are interested and kind of want to reach out and talk about, you know, how can we create these kind of spaces, and they can facilitate that and collaborate as needed. So right now we just have, you know, a simple protocol of what are the steps we follow to kind of set this up, those kind of things. So that's for number 1. For number 2, in terms of research methodology, so the study, you know, I didn't use the word study because it's not meant to be a study. So it's not meant to be, you know, one of the research studies that like I might do in terms of mixed method or focusing on qualitative. So that's why I didn't have like, did I use thematic analysis? What did I use to kind of do that? Because there was no coding, nothing involved. Those were just themes that kind of emerged in a more just you know, kind of looking at what are the things that came up, but it wasn't methods specific or anything like that. The same way the survey was just a very simple Google form, asking women in the community, what are you needing? When are you available? So there was no pre-post data that was collected, and it's definitely not meant to be a research study. It's just meant to be more of a practice-based initiative, trying to meet the needs in the community. It would be cool to actually, you know, turn this into a research study and actually collect data and see, you know, how connected women feel in the community as the project keeps developing. In terms of COVID, oh my, yes, for sure. I think a lot of women in the community were thankful that the space still existed, because while the mosque is closed, they can still connect. And at the same time, what does connection mean, you know, online versus face-to-face would be a really cool thing to study. We just had one face-to-face meeting, and then all the other 5 were via Zoom. And thinking about as well, you know, when people come face-to-face, they kind of leave everything else. When we're coming, like you and I and everyone else on this group, we have our families, we're in our house, right? So we bring all of that with us. So what is the power of attending groups like this in both settings would be cool to look at. Thank you for your questions. I'll connect with you for sure. Awesome.
Okay, so for time's sake, if it's okay, we're gonna move to the next one. But thank you for that.
Let's do it.
Appreciated that presentation. It was really nicely done. Okay, so next we have a presentation titled Sakina Wellness Services Needs Assessment, What is Important to Gen Z Muslims? Speaker Alina Raza, who is here today, is an EDD candidate at the University of Toronto and currently working as a psychoeducational consultant with the Ottawa Carleton District School Board. She holds a BSc in psychology, and in 2019, she graduated with the Master's of Art and Development Psychology. Through her work with multiple nonprofit organizations, Alina has experience working in the field of child development, autism, family resilience, crisis intervention, educator burnout, and curriculum development. Now, Alina, do you want me to play your video, or do you want me to just put the poster up and then you can speak?
You can just play the video.
Okay.
Thanks.
Mm-hmm. Yeah.
Assalamu alaikum. My name is Alina Raza, and I'm a researcher for Sakina Wellness Services. We are a new organization located in Ottawa, Ontario, dedicated to providing culturally integrative mental health and family services. This research was conducted by social worker Pierre-Louise, psychotherapist Dr. Saeed Kianpour, and myself. I presently hold a master's degree in developmental psychology and am currently pursuing my doctorate in school and counseling psychology at the Ontario Institute for Studies in Education at University of Toronto. As a new organization, we felt it was best to make our first foray into the world by seeking to understand the community that we're aiming to serve. Hence our first project, the Sakina Wellness Services Needs Assessment. What is important to the Generation Z Muslim? We hope that this study will be the first in a series dedicated to understanding the needs of the Ottawa Muslim community as a whole. In the case of Muslim youth, both anecdotal evidence and past literature make similar stipulations. This subgroup of our Muslim community is disproportionately impacted by intergenerational conflict, the struggle of understanding identity, and the many byproducts of that search. Growing up in a Western world with Islamic ideals is no easy feat. Sakina Wellness Services felt that the best way to help would be to first hear from the Muslim youth what their experiences were and what they felt would be the most beneficial in helping along the healing process of the Muslim Youth Collective. To achieve this goal, there was much deliberation on the appropriate methodology amongst our mental health team. Ultimately, we decided on using a qualitative approach using 2 focus groups, followed by an anonymized survey. The focus groups followed a semi-structured interview format and were divided by gender. Historically, gender factors are ignored or overlooked as an important source of data. As such, very little information exists that compares and contrasts experiences, symptomology, pathology on the basis of biological sex and gender. Additionally, as a Muslim organization, we felt it was necessary to uphold Islamic ideals and allow for a space where each participant felt comfortable sharing their perspectives. After a short recruitment period, we conducted our focus group through a secure online platform, WebEx, with 6 female and 6 male participants for a total of 12 participants. All of our participants ranged in age from 18 to 25. Each focus group lasted approximately 2 hours and provided us with rich information. As we'd hoped, we were able to gather information about the precise contemporary needs of Muslim youth in Ottawa. We hope to be using the following results to inform future programming for Sakina Wellness Services as well. The focus groups themselves were more of a guided discussion. As such, the major themes that emerged were a natural consequence of the questions that were being asked. The responses were thematically analyzed with the guiding questions as a template, and the major themes that emerged were as follows: needs of the community, known resources, barriers to accessing resources, as well as suggestions for future programming. For the purposes of this particular presentation, I will only be discussing the theme of needs of community. The responses are recorded here on the poster itself. As you can see, blue represents male participant responses, pink represents female participant responses, and any common theme between the 2 participant groups has an asterisk right next to it. What was particularly interesting about the findings were where the differences in perspectives lie. Male participants spent a significant portion of their session discussing ideas of success and what it means to find purpose in modern day society. For example, on the topic of purpose, one male participant said, "I feel like a lot of men these days are lacking a sense of purpose and don't really have direction to their lives. And I think this could definitely be addressed through education and helping them find fulfilling careers and giving them grounding through their physical beings through physical activities. I feel like some physical activities would definitely help men with their confidence and help them feel more grounded and find purpose." Female participants, on the other hand, spoke about the impact of gendered stereotypes on their platonic, familial, and romantic relationships, as well as the impact of these stereotypes on their careers and parental expectations. For example, a female participant accounted an important academic decision she had to make, saying the following: "I remember when I was deciding what university to go to, family and friends would constantly say, you know, there are more Muslim guys in X city, you should go there. They just see me as a potential bride." Additionally, male participants spoke to issues that impacted the community on an individual level, such as difficulty finding like-minded people and feelings of isolation. For example, a male participant indicated the following: "Here in the West, from my experience, you can feel feelings of social isolation when you relate to people on levels like, you know, you have the same interests as me, you're not like me enough though. For example, I don't speak Arabic, so I never fully feel a part of the community. If you know, people who look like me and have the same religion as me say I don't belong, then where do I belong?" Female participants tended to focus on the community as a whole, bringing up issues such as racism or the Sunni versus Shia conflict. One female participant said, "I started having more discussions with my parents and grandparents lately about modern movements and racism and comments in the community that people make. I finally had enough and I've started to use my voice." Our qualitative data shows that while the male and female participants do have distinct perspectives on what are the most urgent needs in the greater Ottawa Muslim community, they do converge on a number of points as well. Most notably, both sets of participants agree on the following: there is a massive need for Muslim mental health professionals in general, but especially those that can address balancing dual identity and faith, parenting, conflict management, and generational trauma. On the topic of blatant lack of Muslim representation, a participant said, "On a professional level, I've never had a Muslim doctor in my life. Having one, I feel, would help even just with comfort levels. They would understand your values, the way you were raised, and the household you're growing up in. Not having Muslim representation in the mental health field is a barrier in seeking mental health help." A male participant spoke on balancing dual identity and faith with the following. I find there are a lot of youth, boys in our community that struggle with confidence. This is partly because when they're at home, they're immersed in one culture, at school, another culture, and at mosque, yet another culture. And maybe they can relate to each culture a little bit, but they don't feel like they fully fit in anywhere. On the topic of generational trauma, participants share some insightful family dynamics. Eventually, our parents' problems become our problems, which isn't healthy. Parents constantly put their problems on their children. Ultimately, kids really suffer the most. They get all this pressure from their parents, and their parents are fighting through their kids, which is an even bigger problem. Additionally, both sets of participants indicated difficulty in finding success in non-traditional fields, whether that be due to lack of access/understanding or due to familial pressure to follow traditional routes. One participant said, I feel like people have a very narrow idea of what you should do with your life and career. You either have to be a doctor or a lawyer or an engineer. Areas like social work and psychology and all of these things are lesser known, and I feel like people are a bit more cautious to go into these fields. There's definitely a lack of support. Another participant indicated, I think there's a bit of discrepancy in understanding between first-generation immigrants and second-generation immigrants, that we are no longer working to survive, and we can build up a life doing what we want to do instead of just making money and living paycheck to paycheck. My colleagues and I went into these focus groups with an open mind. We had some ideas of the kinds of things we might hear from our participants, but we were also quite surprised by the caliber of our participants, as well as the depth and breadth of the information we were able to gather. The youth are certainly experts in their experiences and what they need. In the next coming months, the team at Sakina Wellness Services hopes to put this research to work in developing programming to start addressing these struggles. Thank you.
Okay. So I'm going to thank everyone for submitting their presentations, and I really enjoyed them. So I think for time's sake, we're going to end it right here, and hope to see you all at the welcome ceremony.
And please check your chat. I sent you a DM.